Hello everyone, thank you for tuning in. I'm Tam Nguyen and I'm your host today for this Facebook Live. As some of you may know, March is National Colorectal Cancer Awareness Month, and we are here today to talk about colorectal cancer. I am joined today with Dr. Stephen Hanauer, our Medical Director at the Northwestern Medicine Digestive Health Center, and Dr. Scott Strong, our Surgical Director of the Northwestern Medicine Digestive Health Center. Now, before we begin, I just want to remind you that the information provided today is by no means a substitute for the advice from your physician. If you have any specific medical questions, please consult with your physician or make an appointment with us here at the Northwestern Medicine Digestive Health Center. So let's dive in. So, according to the American Cancer Society, excluding skin cancers, colorectal cancer is the third most common diagnosed cancer in both men and women. Now, Dr. Hanauer, with this statistic in mind, what are your thoughts on the importance of colorectal cancer screening?
Well, the reality is that colon cancer is actually the only preventable cancer by screening. So, for instance, women get mammography or mammograms to identify or find cancers. By doing colonoscopy and identifying precancerous polyps, we're actually able to remove them at the same time, and that actually prevents the development of colon cancer. So the importance of screening is that it is a preventable cancer and not just early diagnosis.
Thank you, Dr. Hanauer. So, Dr. Strong, we received a question here about fecal occult blood tests and whether it is an appropriate substitute for a colonoscopy. What are your thoughts?
Sure. So 2 years ago, there was the U.S. PSTF, which is a national organization that provides guidelines for cancer screening, came out with the latest update. And they do talk about doing these fecal occult blood testing as a modality that we can use for screening for colorectal cancer. It's to be done each year with or without a sigmoidoscopy, which is just an abbreviated colonoscopy, every 3 to 5 years, ideally. But again, for the same reasons that Dr. Hanauer stated, the fecal occult blood test is just detecting something that's already there, hopefully at an earlier stage, whereas the colonoscopy will actually prevent the development of cancer as well as detecting anything that might be there abnormal.
And indeed, if a patient has a positive test for fecal occult blood, that's a signal that they need to go on to actually have a colonoscopy.
Yeah, and unfortunately the testing isn't nearly as sensitive or specific for identifying colorectal cancers as what we see with colonoscopy.
So it sounds like colonoscopies are probably the way to go with colorectal cancer screening, but we are receiving questions about bowel preps and some references to the dreaded bowel prep. Dr. Hanauer, do you any options that we might have out there for bowel preps?
Well, certainly, but let me emphasize that there are factors that actually improve the results of colonoscopy, and there are patient factors and doctor factors. Here at Northwestern, we do everything we can do to impact on the doctor's factors and in making certain that we all, when we're doing colonoscopies, are meeting the guidelines and actually have an appropriate detection rate for our patients. Now, the patient factors that are important are really getting the bowel clean enough so that we can see and actually identify these lesions that are really under 1/10 of an inch in size. So we're looking for very small things. The colon needs to be completely cleaned in order to do that. And happily nowadays, there are a variety of different preparations that can be used. Now, I know a lot of the audience is interested in a pill preparation. And unfortunately, what we found is that the pill prep, particularly in older individuals, puts them at risk for some kidney damage. So most of us prefer a oral liquid solution. And there are several different ones on the market. You don't always need to drink 2 gallons of fluid, but you need an adequate preparation. The best way of doing it is actually splitting the preparation with liquids both in the evening and then, unfortunately, waking up in the middle of the night to prep for the morning. If you have an afternoon procedure, it's possible to prep some the night before and then finish off in the morning. So it also depends on the timing of the procedure.
So we're getting a question about how old you should be for your first colonoscopy? Is there a age limit? When should you start?
Yeah, so typically the guidelines now state that that for most of us, begin at the age of 50, and then it's done every 10 years. And then once you hit the age 75, we start to look at the individual and decide whether or not it should continue. Mm-hmm. But after the age of 85, it's rarely recommended for screening purposes. Now, there are some individuals, such as those that have a family history of colon cancer or colon polyps, or a history of inflammatory bowel disease and different things, where we'd actually start this screening at an earlier age, 40, or sometimes even earlier than the age of 40.
Are there any specific symptoms that they
well,
should be looking for?
Even before we go to symptoms,
okay.
Let me add something to Dr. Strong, because the American College of Gastroenterology strongly advocates for African Americans that screening begin before the age of 50 and at the age of 45. Mm-hmm. And that's just because the risk is different for individuals. Those who have had a family history or who have inflammatory bowel disease are at risk for earlier cancers, and likewise the African American population. So we do need to adjust it by ethnicity as well.
I'm getting another question about...
But you didn't finish your other question.
Oh, I'm sorry.
I interrupted you.
Go ahead. Symptoms. So what are some of the things that folks under the age of 50 should be asking their physicians if they're not at 50 yet?
That's an easy question. The primary symptom that we would be concerned about is blood in the stool. That's the earliest symptom of the development of polyps or precancer or even cancers. By the time patients are developing significant symptoms related to intrusion of the cancer into the bowel wall, that means it's already been invading, and that's going to reduce our potential to cure. But blood in the stool is the primary factor, or a change in bowel habits.
We're getting questions about a video colonoscopy. Can you guys tell us a little bit about that and what that might be?
Well, it can be a term used for a couple different varieties. Okay. One is a capsule that you swallow that mm-hmm. has a small camera at the end of it with a strobe light that each time it strobes, it takes a picture, and so it will take hundreds of pictures, if not more, as it passes through the intestine. But you have to understand it initially, after ingesting the pill, it'll go into the small intestine, mm-hmm. and then has to pass through yards and yards of the small intestine before it gets to the colon. And so we use it predominantly for looking at abnormalities that may be located in the small intestine, because it's not nearly as sensitive and accurate for the large intestine or colon as what we see with colonoscopy. Now, there's also a CT colonography, which is a CAT scan of the colon, that maybe 10, 15 years ago we thought was going to be the solution. But it's pretty limited now, just to those people that can't tolerate a colonoscopy. But still, you have to go through the bowel preparation. You still have to have air placed into the colon. And so while it's a very reliable test, again, just for identifying things, not removing them, but sometimes we'll use that imaging modality to look for polyps or tumors.
But we need to emphasize that if you're going to do one of those alternative strategies, a pill camera or an imaging such as an MR, you still need to do a good bowel prep.
Got it. What about, is there any connection with diet or probiotics with colon health and colon cancer?
So the risk factors for colon cancer, there's some of them that we can't manage, and it's just our lot in life, and then others that we can. So the things that we can't change is our age, our family history, ethnicity, as well as race come into play. If you have the inflammatory bowel disease, those things we can't change. But the things that we do know that are linked to a higher risk for colon cancer are if you smoke, it increases both your risk for colorectal cancer as well as your likelihood to not survive colon cancer, as well as being obese or overweight. That increases your risk and risk for death from colon cancer. If you eat a lot of red meats, processed meats that you fire up to a high temperature, those are all things that carry an increased risk for colorectal cancer. If you're not active or don't exercise on a regular basis, that increases your risk. And so we're not quite sure about eating a diet that's high in fiber, fruits and vegetables and things like that, but it seems that that probably has an influence also in decreasing your risk for colorectal cancer.
What would you say are some of your most common questions that you receive from patients about colorectal cancer and preparing for their colonoscopy?
Well, that's really two separate questions. The first is, their risk for cancer. Now, I mentioned that blood in the stool is a common symptom of colon cancer and an early symptom, but I would predict, or I would assume, that about 90% of people who have small amounts of blood in their stool, particularly if they're young, are not actually going to have cancer. Nevertheless, they need to be evaluated for that possibility or other diagnoses that could cause blood in the stool. Your other question about the preparation is often brought to us by patients, and as I've already said, there are several different preparations that can suit the individual based on the time they want the examination, the time of the day, and their background. So I think there are many individual factors that can be discussed with the physician.
Dr. Henner brings up this issue about younger people and bleeding and symptoms. And about a year ago, there was a report that came out that caused quite a stir, and that was that we're seeing more and more colorectal cancers in people under the age of 50, under the age of 40 even. And the question is, why is that happening? And we don't know why. What we do know is then that people over the age of 50, because about 2/3 of us are now compliant with our screening, and so we're finding these precancerous polyps, removing them, and that prevents cancer. So we're not seeing an increase in colorectal cancer in people over the age of 50 because we're screening. But those that are under that age that don't fall into the screening guidelines that we typically talk about, colorectal cancer is on the rise. It still represents only a minority of the patients that have colorectal cancer, the average of someone with colorectal cancer being late 60s, 70s. But we are seeing that younger people are developing colorectal cancer where we didn't see it before. And so consequently, symptoms such as bleeding, change in bowel habits, pain, those should not be ignored. They need to be evaluated by your doctor. And if they persist, then you probably should have some type of more thorough evaluation.
And that's actually an excellent point, because you bring up the difference between screening, which is performed in a healthy population, in asymptomatic individuals. People with no symptoms whatsoever need to have screening. On the other hand, if you are having symptoms such as blood in the stool or change in bowel habits, that's not actually considered screening. That's a diagnostic test to determine the cause of the bleeding or the change in bowel habits.
So, Dr. Hanna or Dr. Strong, we're getting a question here about someone who might have a family history of colorectal cancer. What are some of the things that they can do to see if they're at higher risk or not? Are there testing? I mean, we're hearing a lot about inherited colorectal programs.
Okay, so we're hearing, and we found actually, that younger individuals are developing cancer. Part of that is just part of our environment, as Dr. Strong said. Individuals who have a family history of polyps or colon cancer, independent of their age, should start being screened, even if they're having no symptoms, 10 years before the youngest diagnosis within the family. So if your father developed colon cancer at the age of 50 or developed polyps at the age of 50, their children should be screened at the age of 40, even before the typical guidelines. We're also recognizing that there are some families that have a very high incidence of polyps, beyond that we just presented. If there's a significant history of cancer or polyps in multiple family members, then we're going to advise a referral to a genetic counselor, because that's a trend that can be passed down from generation to generation. And maybe Dr. Strong wants to add more to that.
Yeah, so about 6 to 8% of individuals that develop colorectal cancer have an inherited form that we can actually identify. And we can kind of, we know, or we can sense who those individuals are by asking about their family history. Other members that have had colon cancer, there are also some other cancers that are associated with colorectal cancer in these inherited families, such as ovarian cancer, endometrial or uterine cancer. So, and looking to see how many different generations have been impacted. Then also, when we find a polyp or a cancer and we send it off to the lab, we can do special staining on that cancer to look for changes that we see that would indicate a higher association or higher risk for an inherited form. And then we can use more targeted genetic testing to see if indeed it is one of these inherited forms. And so, because this has significant implications as to the type of operation you would do for colorectal cancer, how often you survey the person after they have the cancer taken out, what you tell their family members as far as surveillance beyond the colon. In women, you could be doing ultrasounds and things like this, trying to find these other cancers that would otherwise be undetected in these people with an inherited form of the colorectal cancer.
Tam, you had asked me earlier what are common questions. Mm-hmm. One of the most common questions actually pertains to surgery, because one of the big fears that patients have about colon cancer is that they might need a bag, an external appliance.
And what are those called, Doctor?
Those are called stomas or colostomies or ileostomies. And Dr. Strong, I don't think that that's the norm anymore.
No, it's actually quite unusual. So in this year, we predict there will be about 140,000 people that will be diagnosed with cancer of the colon or rectum. And if you have a colon cancer, it'd be very unusual that you would need one of these stomas or ostomies. And rectal cancers represent maybe a third or less of the cancers that we see. And even at that, it's not typical that you need to have a permanent bag in order to manage the cancer. It's only for those cancers that are very close to the outside, or people that have significant other health issues or problems with control to begin with, that we would have to obligate them to having a permanent colostomy. So for the most individuals, they're able to have the operation and return to kind of a normal bowel function without concerns about things such as that.
And I understand there are some newer surgical techniques you're using.
Oh, yeah, we continue to kind of push the envelope to try to help patients avoid these things, but at the same time we need to balance quality of life and make sure that the life that we're providing these folks is appropriate. And so we carefully ask questions about that so that we not only are curing the cancer, doing it safely, trying to avoid a permanent bag, but maintaining a good quality of life.
So for those patients who do end up needing a permanent bag, so to speak, what are some of the resources that are out there for them to be able to manage?
Sure,
those?
and we've looked at this extensively, and we know that there pretty much anything that you've done a year ago, you can still do with a colostomy or ileostomy, and it's just this fear about it. It's the unknown, and I have patients that are a lot more active than I am with these stomas. So, but we have registered nurses that take care of patients with these ostomies, and they are very insightful as to different ways to help people cope with this, especially if you're active swimming every day, running marathons, bicycling.
And you can
whatever.
Do all of that.
All of those things are possible. A few years ago, I was on a long bike trip with a big group of individuals. It's the bicycle ride across highway every year. And this guy goes past me and then slows down and turns his head and says, "Dr. Strong, how are you doing?" And it's one of my stoma patients who's going past me on this thing. So, yeah, you can be very active and fine with a stoma.
That's great. So back to colonoscopies. We have a question that says, I've heard that after a colonoscopy you pass gas a lot. Is that true, and why might that be?
In the past, that may have been true, because in order to visualize the colon through this small scope, we have to administer air to be able to see the entire bowel wall. But nowadays, we're no longer using air. We're using carbon dioxide, and that doesn't influence the patient. It's absorbed very rapidly, and so that problem of having gas afterwards is really not significant anymore.
Yeah, it used to be about 5% of people would potentially miss work the next day because of this bloating and cramping that they had
But
from
not
all the
anymore.
air. But with the CO2, we're not seeing that any longer. So it's really been an improvement in these screening tests.
Yeah. So, we do get questions frequently about why there's a need to have someone present to help take you home after the colonoscopy. I mean, if things have been improving with technique and you're using CO2 now, why might that still be that we need someone to help escort us home after the procedure?
Well, the majority of colonoscopies are performed with some form of sedation to relax the patient. Now, frankly, everyone doesn't need it, but the vast majority of people are desiring that. The colonoscopy does stretch the bowel walls, so there may be some discomfort with that. There's no discomfort if we remove polyps or take biopsies. But because of that stretching, many people want to be, or most people want to have some form of relaxation or sedation. And that sedation doesn't wear off right away, and it can last for a number of hours afterwards. So in individuals, or for individuals who have colonoscopy with sedation, whether it's sedation by the doctor who's performing the test or with an additional anesthesiologist, it's recommended that they don't drive for the hours afterwards, just to prevent accidents.
Thank you. So you guys have been busy building our Northwestern Medicine Digestive Health Center. We're getting questions about other opportunities for folks out there to learn more about the center, get involved. Any information we can provide there?
Well, we're very fortunate to be supported by the Digestive Health Foundation, which is an affiliate foundation here at Northwestern that supports the Digestive Health Center. And on our foundation website, digestivehealthfoundation.org, you can see many of the activities that we have, including the research that's going on, profiles of our different physicians, our different expertise, not only for colorectal cancer and screening, but across the field of gastroenterology and also colorectal surgery.
We are getting a couple of questions about past family history of colorectal cancer and the types of specialists that folks should be reaching out to and talking to. So is the first step to see your gastroenterologist, or?
Well, I think the first step is to see your physician and ask if they need to be referred to a gastroenterologist. Screening colonoscopies can be performed by gastroenterologists such as myself, surgeons such as Dr. Strong, and in different areas where maybe there aren't as many GIs or colorectal surgeons, even surgeons or general practitioners are doing some of these procedures. So I think it starts with your physician for appropriate referral.
But again, it takes an astute physician with a sense of question about this family history, and that it's not just so much as asking if there's a family history, but kind of delving into it with a little bit more specificity, asking about what members had cancer, what type of cancer, at what ages, and then from that you can kind of formulate if they're at an increased risk, because that has implications as to whether or not we need to get a genetic counselor involved. And usually you're going to have to go to a major academic center in order to have access to someone that can do that type of counseling and testing.
So some of our audience members are commenting that they associate colon cancer with men. And how common does this disease affect women, and should women adhere to the standard screening guidelines, or are there any special guidelines for women?
So the distribution between the sexes is pretty equal. There are a few, it's skewed a little bit towards men, but not appreciably. And so the same guidelines that we use are applicable for both men and women, and there's really not much difference as far as how we do that. So it's not a men only or women only kind of disease.
Mm-hmm.
It's an equal opportunity disease.
We estimate that about 1 out of 22, 1 out of 21 individuals will develop colorectal cancer during their lifetime. So it is a fairly common kind of cancer. And but again, with appropriate screening, hopefully we can avoid a lot of the cancer in individuals by taking out these precancerous polyps before they ever have a chance to turn into cancer.
Mm-hmm. So you guys work together very closely. Can you tell us a little bit about how a patient would potentially see the both of you, or how you would collaborate together to take care of your patients?
Well, I'm a gastroenterologist. I'm a medical physician. And so patients who have symptoms will usually come to me. unless there's symptoms around their rear end, around the anal canal, hemorrhoids or conditions around the anal canal will often be referred to someone like Dr. Strong first. But what we will do is we will take the patient through their symptoms to the point of diagnosis. If they do indeed have a colon cancer that's identified or polyps that we cannot remove, in that case, I will have them see Dr. Strong and take it from there. But that may not even be the end. Unfortunately, some patients may have cancers identified that have spread, and in that case, we may need to invoke other specialists such as oncologists or radiation therapists.
Yeah, so historically, Dr. Hanauer and his GI colleagues would kind of be segregated over with the other people using medication to treat disease, and I'd be working in the same building as other surgeons that use an operation to take care of disease.
But not necessarily in the same location.
Correct. So geographically remote, and what we learned is, the patients, if they have a colorectal cancer or some type of GI disorder, whether it be about a swallowing problem or reflux or a variety of things, inflammatory bowel disease, they need to see both of us. And so it didn't make sense for the patients to be wandering back and forth between different facilities or different buildings. And so now, for the last few years, we've been co-located in the same space. And so Dr. Hanauer and I literally are 20 feet apart every Wednesday seeing patients. And so it's not uncommon for him to be seeing a patient that may need an operation, or I'll stick my head in, and vice versa. So it's worked out very well, and I think the patients really appreciate the fact that they can see two types of specialists depending on what their problem turns out to involve during the same visit.
And we can share our donuts and coffee.
So we are nearing the 3-minute mark, but I do have one other question for you guys. So you guys you're both innovators in your field. What would you say is the most exciting thing that's coming to light in terms of new procedures, new technology that might help in terms of managing colorectal cancer?
Well, I'm actually going to defer to Dr. Strong, because on the screening end, we continue to improve with our ability to identify polyps either through colonoscopy or some other techniques, and Dr. Strong mentioned pill cams, which will identify polyps but won't preclude the need for doing a colonoscopy. On the other hand, there have been many advances now in surgical rates and hospitalizations. I mean, when I was training a number of years ago, patients who had colon surgery were in the hospital for weeks.
Yeah.
Nowadays?
Yeah, well, it's changed, and Dr. Hanauer is being modest. He and his colleagues now are taking out polyps with a colonoscope that in years past the only way that was removed was with a big operation. And so there are fewer patients that are requiring surgery because we can do things with the colonoscope. But on the surgery side, instead of making the big cut up and down the middle of the abdomen like we used to do, now we're able to do things laparoscopically or through a more minimally invasive approach, where typically with 3-4 incisions you're able to take these things out. And we have also learned how to minimize kind of the insult, if you will, to the patients in the course of this. So it's not uncommon for people to be going home 2 or 3 days after they've had their operation and feeling like the recovery is much more comfortable and not nearly as taxing on them. And then, our colleagues that are looking at the cancers under the microscope, we're beginning to look at more and more markers for these cancers to determine what types if the chemotherapy is indicated, what type of chemotherapy to use, so that we have more of a tailored approach to these individuals, and in improving survivals as a result of all of that. And so it's a concerted effort where you have like-minded physicians coming together, providing care to the patients that's really centered around what's best for them and giving them the best possible outcomes.
And ultimately, it's a personalized approach.
Yeah. Well, it looks like we are just running out of time. Thank you so much, Dr. Strong and Dr. Hanauer, for taking the time today to talk to us and teaching us about colorectal cancer and screening. And I wanted to thank everyone out there for tuning in with us. If you would like to learn more about our Northwestern Medicine Digestive Health Center, please visit our website at dhc.nm.org, or you can call us at 312-695-5620. Thank you for tuning in. Have a great day, everyone.
Thank you.